morning to all of you. We are starting the Tony Fernandez video session, award session. So welcome to you all. Welcome to all the award winners. And Dr. Rosemary and me, Dr. Sudha, will be moderating the session. Dr. Rosemary, please.
Good morning, ladies and gentlemen. Welcome to the prestigious Padma Shri Dr. S. Tony Fernandez Video Awards final, a very prestigious competition instituted in the name of one of the most favorite, most revered names in ophthalmology of India. This year, we have had 30 videos competing for this prize. And I must, from what I've heard, the scientific committee had a very difficult time. And they have finally selected 6 finalists from all the 30 entries received. Anterior segment, posterior segment, all held up a very tough competition. And Sudha ma'am was just telling me how the scientific committee chairperson even has his arm in a splint after that. Now, for the battle of the 6 finalists, we have an eminent panel of judges seated in front from all over the country and even from abroad. So introducing the judges to you, we have Dr. Partho Pratim, Senior Consultant UVR Shankar Nethralaya, Dr. Sharavanan, Senior Consultant VR Surgeon Aravind Coimbatore, Dr. Satyan, Senior Glaucoma Consultant Coimbatore, Dr. Ebi, Consultant with Interest in Glaucoma UK, Dr. Chandrasekhar, Consultant Aravind Coimbatore, Professor Andrew Braganza, Consultant Glaucoma University Hospital, Southampton, Dr. Kausalya, Professor Department of Neuro-Ophthalmology, Aravind Madurai, and Dr. Minu Mathan, Senior Phaco Surgeon Consultant, Chaitanya Eye Hospital.
Sorry, that's a mistake. Professor Andrew Braganza is from Vellore, CMC Vellore.
Okay, I'm sorry for that mix-up. Anyway, so it's all up to the judges here, and I hope all the 30 authors are ready, sitting here, and I'm handing over the mic to Professor Dr. Sudha ma'am to declare the first finalist.
So congratulations to all those who presented or all those who gave their videos for awards. Now the first 6, it's not in the order of award or the marks. It is just in a random order, but the 6 selected, I would like to call upon the first person to be on the podium when the video is being presented. So the chief and presenting author of this is Dr. Shebin Salim, Restoring the Blink. Please come up onto stage.
We have just 1 hour. This is to be a very tight-packed session. The first presenting author, Dr. Shebin Salim, please.
Restoring the Blink. Has many devastating psychological, social and physiological consequences. The primary concern is prevention of visual loss secondary to exposure keratopathy and corneal ulceration. When it comes to the management, we are familiar with the supportive measures and static methods like tarsography, goldweight insertion, levator resertion and canthal tightening procedures. These methods correct the lag of thalamus but can sometimes result in poor cosmetic outcomes and most importantly the eyelid blink function, which helps in maintenance of a stable tear film and healthy ocular surface, is not restored. The dynamic methods including motor neurotization and muscle transfer techniques aims to restore form and function of the eyelid and periorbital periocular region. Temporalis muscle transfer is the most commonly performed muscle transfer in facial palsy. Though it helps in lid closure during mastication, persisting nocturnal lag of thymus is a problem since the lid closure relies on conscious efforts by the patient to chew. So what is next? Since the primary pathology is a paralytic orbicularis oculi muscle, why don't we strengthen it or re-innervate it with the contralateral orbicularis oculi? This concept came from two main observations. One is lack of significant clinical side effects on removing preseptal orbicularis oculi and the medial lag of thymus that is observed following a deep dissection at the medial cheek of the nasofacial groove attributed to a medial buccal nerve supply to the orbicularis oculi muscle. This is supported by cadaveric dissection demonstrating a terminal ascending branch of buccal branch of the facial nerve that travels in supromedial fashion to innervate the orbicularis oculi muscle medially. In this video, we demonstrate the surgical technique of orbicularis oculi muscle transfer in case of facial nerve palsy. The procedure is done under local anesthesia. A lid crease incision is made with a radiofrequency cautery on the unaffected side. Subcutaneous dissection is done to separate the preseptal orbicularis muscle from the skin. The desired width of the muscle is 10 mm. A flap of healthy orbicularis muscle is raised, remaining attached medially via a wide pedicle node to interfere with its nerve and vascular supply. Then on either side of the nasal bridge, a 10 mm skin incisions are made above the medial canthal tendon to make subcutaneous supranasal tunnel. For the ease of tunneling, a vertical incision is made at the root of the nose. The flap is tunneled through these incisions. Once the flap is tunneled, it is longitudinally divided into superior and inferior halves for upper and lower eyelids. Side cuts are made on each half to increase the length of the muscle. The flap is attached to the paralyzed orbicularis muscle with the help of 6 polyglactin sutures through small skin incisions. Skin incisions are closed with 6 polyglactin sutures. Pre and post-operative photograph showing a good lag of thymus correction. This patient also underwent a direct brow lift and a lower lid tightening with skin graft. Video showing a return blink response on the paralyzed side in coordination with the normal side post orbicularis oculi muscle transfer and retractor resorption. Same patient, here we can see the medial lower lid support by the transferred orbicularis muscle fibers. Few more happy patients. So how does it work? The transferred orbicularis oculi muscle flap readapts the paralyzed motor units by changes on the muscle surface and formation of neuromuscular junctions. which in turn lead to motor neurotization of the orbicularis oculi muscle on the paralyzed side. In addition to restoration of blink reflex, this also improves the medial eyelid support. To keep in mind, a complete blink may not be restored by this procedure. Concurrent static methods should also be considered in case of significant lag of thalamus or lid laxity. To conclude, orbicularis oculi muscle transfer improves the voluntary lid closure and spontaneous blink reflex. This should be considered in patients with a facial palsy for a better functional outcome and patient satisfaction.
Okay, thank you, Dr. Shebin. I think that was a very complete video, teaching video with every step given very beautifully in correct time. So please, judges, please, if any comments? Any comments, any questions?
It's nice to see that beautiful actually, but is that the other eye will be like, they may have a ptosis over a period of time, like because of the overaction? Like say about a couple of years or 3 years later. I think you have a follow-up of about 1.5 years now.
Yeah, sir, 2 years follow-up is there now.
Yeah.
No ptosis or any other lack of thalamus. Nothing has developed in the other eye.
Okay.
Any other comment? Yes.
That was very interesting. My question to you is, what is the optimal time for intervention?
After 6 months.
And before?
Optimal time of intervention, so if there is significant lag of thalamus and exposure keratopathy, initially we can do a tarsorrhaphy and other supportive treatment. But for the definitive management, we have to wait 6 months.
Yeah, and can you do it, say, 5 years down the line?
Yes, sir. If the patient is symptomatic, anytime we can do this procedure.
Okay, thank you.
Is it only for Bell's palsy or any other tumor-induced neurological complications?
Yes, ma'am. For tumor-induced neurological complication, which is not where there is complete transaction of the nerve, also we can do this.
Okay.
Is there any instance where this operation has failed? You've done the surgery very well with no problems, but it's failed to have an effect.
No, sir. We have done in around 6 patients, but no complete failure is there. But how much it is, it will improve to some extent, but complete blink may not be restored. Okay. And if there is significant lag of, we have to do additional procedures also.
Okay. How long after the surgery do you expect to start seeing a blink reflex?
1 to 3 months.
Thank you.
Dr. Meenu?
Yeah, very nicely presented. Very nice to see. But only suggestion is the background music during when you prepare, no, it should be little down when you talk, and you talk little more boldly. This is a very interesting new concept. You can be very proud about doing this and be bold about it.
Thank
Good.
you, sir. Thank you for the suggestion.
So thank you. The next,
Thank you, ma'am.
next presentation, When the Petals Close Up, a surgical video on primary eyelid repair by Dr. Anna Kurian.
So this is the second of the 6 finalists on stage, Dr. Anna Kurian Mullasheril. She'll be presenting When the Petals
Just
Close.
as the petals of a flower, gracefully closing at dusk, eyelid repair is a task of precise engineering, essential for restoring both function and form. Today, we explore this process in the case of a 45-year-old male who sustained an injury to his left eye from the horn of a goat, causing his eyelids to open up in a way that resembles a flower's bloom. Let's break down the steps involved in this delicate procedure. Step 1. After administering local anesthesia, area is meticulously cleaned to ensure a sterile environment. Step 2. The repair of the upper eyelid margins. Identifying the tarsus, Gray line, anterior lash line, and the mucocutaneous junction is crucial. A vertical mattress suture is taken through the gray line at the same depth and distance from the lid margin on each side of the laceration. An interrupted suture is then placed at the posterior lid margin, which is the mucocutaneous junction. Both tails are left long. A second interrupted suture is placed at the anterior lid margin. The long ends of the first two sutures are then anchored in the knot of this final suture. A similar technique is used for the second lid margin. Step 3. Repair of the tarsus. After careful alignment along its length, partial thickness absorbable sutures are used for tarsal repair. Step 4. Soft tissue repair. The cut ends of orbicularis were approximated using 6-0 vicryl absorbable sutures. Step 5. Skin closure. The tails of the eyelid margin sutures, which were kept long, were buried into the skin sutures such that they are kept away from the corneal surface. Just like a jigsaw puzzle, the focus was kept on approximating the key areas, followed by the rest of the wound. Probing helped to identify the cuts in the upper and lower canalicus. Step 6. After punctal dilatation, mini monoco stent with a beveled edge was inserted into the punctum and pulled so the collar is seated flush with the punctal ampulla. Identifying the nasal cut end of canalicus is one of the most difficult steps in this surgery. In a similar way, the upper canalicular tear was also repaired with a mini monoco stent. Step 8 was the repair of the lower conjunctival fornix with continuous, absorbable 6-0 vicryl sutures. Step 9. Pericanalicular sutures for the fixation of mini monoco stent and medial canal repair were done using 6-0 vicryl absorbable sutures. Step 10. The last and final step involved the repair of the soft tissue and skin of the lower eyelid. With meticulous attention to detail, the eyelid repair is complete and the patient is on his way to recovery. As we conclude this case, it's important to emphasize the significance of follow-up care and patient education to support optimal healing and prevent complications. Thank you for joining us in exploring the delicate art and science behind eyelid repair.
Thank you, Doctor. And now, very meticulously done, long surgery, but done following the principles of oculoplasty. Beautiful results expected. So, judges, please.
It's a beautiful video. We thoroughly enjoyed the video, and the stepwise presentation was also very good, and there was no shaking and all. Excellent.
Thank you, ma'am.
When was the last follow-up? After how many?
So I think we saw him 1 month back. The last follow-up was around 6 months, like
So how was
post-surgery
the
6 months.
anatomical and the functional integrity then?
It was actually quite good. He followed all the instructions. It was quite good.
Oh, nasal lacrimal duct system was functioning well.
Yes, yes, sir.
No epiphora.
No epiphora.
Congratulations. Good one.
Thank you.
So thank you, Dr. Anna. And now from outside the eye, we are going to inside the eye, calling upon the third presenter on stage, Dr. Shishir Varghese, breaking the mold, unconventional techniques in conventional vitreoretinal surgeries. Please, Dr. Shishir on stage.
Break the mold. Unconventional techniques in conventional vitreoretinal surgeries. In the ever-evolving field of ophthalmology, vitreoretinal surgery stands out as a beacon of rapid technological and procedural innovation. This shift has been driven by groundbreaking advances in imaging technologies, surgical instruments, and pharmacotherapy, all aimed at enhancing surgical outcomes and patient safety. This video will delve into some innovations in vitreoretinal surgery, highlighting their practical applications and the future they can shape for both practitioners and patients alike. We present to you some challenges in vitreoretinal surgery and their innovative solutions. Challenge 1. Frequent toggling of microscope illumination. During vitreoretinal surgery, the operating room main lights are dimmed to enhance surgeon focus. Throughout the procedure, the microscope light is periodically switched on and off to better visualize the cannula during instrument exchanges. A constant illumination is therefore not possible. We need an economical tool that provides continuous illumination and facilitates efficient instrument exchanges in vitreoretinal surgery. We introduce to you the glow port. This is the glow port, a 3D printed phosphorescent glow device. This is compactly fitted over a 25-gauge trocar cannula. After placing the infusion cannula, both the superior cannulas are placed with the glow device on it. The glow port is then exposed to the microscope light as well as light from the endo illuminator. Under dim room light conditions, we visualize the glow port glowing in the dark. The glow port, with its property of phosphorescence, helps us with smooth and efficient instrument exchanges without repeatedly switching on and off the microscope light. The photoluminescence or glow stays for 10 to 15 minutes and it regains its glow after a very brief exposure to the endo illuminator light. Ocular touch errors and effective surgical time is reduced for novice as well as experienced PR surgeons. Challenge 2. Difficult PVD induction due to bullous retinal detachment. This is a case of a 75-year-old patient with a bullous exudative retinal detachment where PVD induction was difficult. We used a 27-gauge intravenous cannula for draining the subretinal fluid as seen here. The soft silicone end of the cannula was left in the subretinal space and PVD could be induced easily over an attached retina. It can be left in this space while performing other procedures. This IV cannula can be foot pedal controlled as well as it can be used in choroidal detachments. Challenge 3. Clot formation over a detached retina. We operated on this one-eyed, 65-year-old diabetic patient with tabletop tractional retinal detachment. Intravitreal anti-VEGF injection was given 5 days pre-operatively. Intraoperatively, A dissection plane was entered and bleeding was encountered right from the start. Eventually, while dissecting the fibrovascular proliferation, there was excessive bleeding which kept increasing even after raising the infusion pressure. Clot removal over a mobile retina was difficult and hence a fluid air exchange was done to arrest the bleed and flatten the retina. This was followed by subretinal TP injection. The liquefied clot was removed with a cutter and residual bleeders were cauterized. Two weeks post-operatively, the retina was attached with the patient having ambulatory vision. He was planned for an early silicone oil removal. Challenge 4. Occult retinal break detection. After pars plana vitrectomy for retinal detachment, other than PVR, missed retinal breaks account for 64% of failed retinal detachment surgery. We load BBG dye in a subretinal injector and using a 41 gauge cannula, inject it into the subretinal space to detect occult breaks. In this case of recurrent retinal detachment, after failing to localize a break, we inject BBG dye into the subretinal space and steamroll it with PFCL. We can observe the dye emanating from the now visible break, seen in slow motion. We should be careful to remove air bubbles from the subretinal injector so as to avoid air bubble injection in the subretinal space. In this case too, we can observe the dye emerging from the now visible break. 3 months post-operatively, the retina was attached in both the cases. Subretinal BBG dye injection is of great benefit as it provides a color contrast and helps in occult retinal break detection. Challenge 5. Small non-magnetic foreign body removal. We designed a custom, intraocular foreign body forceps with blunt tooth tips for easy grasp and removal of small non-magnetic foreign bodies as seen here. The patient had 6x6 vision after foreign body removal. Challenge 6. Aphakia management in corneal diameters greater than 11.5 millimeters. This patient had a dislocated IOL bag complex after blunt trauma. His corneal diameter was more than 11.5 millimeters, hence he was planned for a flanged intraocular lens technique. After removal of the IOL bag complex, an IOL with eyelets was threaded with 50 proline sutures. A flange was created at both suture ends using heat cautery. Using the X-knit technique, suture ends were inserted into the 26 gauge needle and exteriorized, following which the IOL was inserted. The exteriorized suture ends were cut, flanged and buried under conjunctiva. Best corrected visual acuity was 6x6 postoperatively. To conclude, we have showcased a range of innovative techniques that effectively tackle common challenges in vitreoretinal surgery, thereby breaking the mold.
Thank you, Dr. Shishir, and in true Shishir style, breaking the convention with all his inventions. So very good. Thank you, Dr. Saravanan sir. Would like to comment upon it?
Yeah, nice collection of. But the thing is that you have some new and some old techniques which you have superimposed and made into a bouquet. But when you're sometimes clubbing too many things into your sort of bouquet, it dilutes your own innovations. You have some new innovations and you're superimposing with the old other people's innovations, and sometimes it dilutes it. But otherwise, it was good. And this glow port you said, no, it is a little bit bigger than what should be. Like sometimes in a pediatric eyes or in a sort of a small palpable aperture fissure, it may be a little bit difficult to place.
Yes, so we have made one with smaller diameters also, and we made one for 27 gauge also.
The foreign body also was wondering like what is the base when you open, what's the base diameter of the forceps? What is the necessary sclerotomy needed to introduce into that?
This was a custom made by Epsilon.
Okay.
So
it's a negative action or is it a positive action?
No, positive. We have to press and then only.
So what's the size of the sclerotomy site?
No, we have to go by a routine that 20 gauge.
But it's a routine forceps, no? It will need a larger opening to enter, no?
No, it's a opening is very thin. Just that the width when it comes towards the center part, it's a little bigger width. But you still need a 20 gauge opening. You cannot go by a 25 or a 20.
No, 20 gauge only. It's 20 gauge opening.
Yes,
enough?
20 gauge opening is required.
Okay, nice collection.
Yeah,
Dr. Partho, would you like to? Yeah.
Excellent video, Dr. Shri.
Thank you.
Really enjoyed it. Any particular reason for using the AI-assisted voiceover?
My voice I recorded and it was not so great when I test screened it. So I found AI. You can type the text and then the AI generates.
Yeah, I
so
understood, but I was... Thanks.
Thank you.
See, instead of making them ask, making them ask, in credits, give credits to AI program for voiceover. You can just write like that. What is it?
Okay. Thank you, sir.
No, Cecil, I think what he said was very important because when it comes to originality, when you give your voice, even whether it is good or bad, it makes a lot of sense.
Yes.
So that just make sure that next time you give your voice.
Right. Okay, sir.
I think your voice is much more beautiful than the other one.
Okay, thank you.
Thank you. Otherwise, everything was very nice actually. Yeah.
Thank you.
And for me, I was thinking that if we can just give one or two, then we say it's a kadambam. That gives you a little bit more importance for your one or two innovations. It will be even nicer.
Nice. Yes.
Yeah.
So an important message for all. AI can be easily detected by the judges. Good from judges here. Thank you.
Thank you.
Shri. Next.
Thank you, Dr. Shri. And halfway through, calling upon the fourth presenter on stage, Healing of the Whole. Chief and presenting author, Dr. Saurav Damodaran. Please.
Macular holes are full-thickness defects in the foveal neurosensory retina causing significant visual disability. Its surgical management involves vitrectomy, internal limiting membrane peeling, and endotamponade. Our first case is a macular hole of size 650 microns with a best corrected visual acuity of 2 meters. Core vitrectomy and tricot assisted PVD induction is done, followed by staining of internal limiting membrane using BBG. An ILM forceps is used to remove the internal limiting membrane, and it is fashioned as an inverted flap over the macular hole. ILM is peeled 360 degrees around the macular hole, and the flap is trimmed using a vitrectomy cutter so as the flap sits in the hole. The case is closed under C3F8 gas. At 1 month follow-up, the hole is closed, but the layers are not seen. At 6 month follow-up, the patient had a best corrected visual acuity of 624 and the retinal layers can be appreciated. Our second case is a macular hole of size 675 microns with a BV of 3 meters. Using a 25 gauge system, 4 vitrectomy is performed. Triamcinolone acetonide is used to stain the posterior vitreous. Careful PVD induction is done and the vitreous is trimmed all around. BBG is injected to stain the ILM. Similar to the first case, internal limiting membrane is peeled 360 degrees around the macular hole and the flap is fashioned over the hole. Vitrectomy cutter is used to trim the excess flap with a high cut rate and low vacuum. Fluid air exchange is performed. A finished loop is used to reposition the flap over the hole. The case is closed under C3F8 gas. At 1 month follow-up, the macular hole is closed. At 6 months follow-up, the reappearance of the outer retinal layers can be appreciated, and the patient had a final best visual acuity of 6/80. When we look back into the embryogenesis of fovea, it involves the centripetal migration of inner retinal layers, centrifugal migration of outer retinal layers, and the packing of cones under the fovea. Similarly, during healing of a macular hole also, there is centrifugal migration of outer retinal layers resembling foveal embryogenesis.
So that is well documented, 1 month and post-surgery, and the surgery is also, I think you must be recording all your surgeries, and very nice OCTs. So any comments, sir?
The BGM was mild and pleasant. That was good. But the intraretinal surgery, the picture clarity has to be better, I think. And you can avoid that PPT kind of a thing in video. So it has to be better. So shown better.
Okay.
Okay, ladies and gentlemen, from the remaining pool of 26 videos, I now call upon Dr. Bindu S. Ajit for presenting her video on converting MSICS surgeon to MIGS surgeon. Dr. Bindu ma'am, please.
As we move towards the era of micro-invasive glaucoma surgery, we see how a phacosurgeon can upgrade himself to be a glaucoma surgeon by just learning the art of intraoperative gonioscopy. It all starts with a tilt of microscope 30 to 35 degree towards the surgeon. The patient's head is moved 30 to 35 degree away from the surgeon. The patient is asked to look away and the microscope is aligned for better visualization. Adjust the eyepiece to prevent this streak on the neck and also press the XY coupling knob so that we get a more wider range of zoom in and zoom out and focusing too, which is very much required in a gonio procedure. Coming to docking, cohesive viscoelastic is used to inflate the eye and also over the cornea. With a non-dominant hand, a lens is placed over the cornea. Here it is the Schwann-Jacob lens, and then focus to visualize the angle structure. The view, what we want is the on-face view where the angle structures are clearly seen and focused and they're facing forward. The approach with the device is easier in this view. This is the Glaucos eye prism which provides a wider angle of visualization. What we don't want is a steep angle view where the anteriorly placed lens, the structures are obscured and it is difficult to perform the procedure with the instrument. The troubleshooters that are commonly encountered are blood under the field, which obscures the visualization of the angle. For gonio procedure, the phacosurgeon has to make the incision more clear corneal to prevent bleeding. Undue pressure during the initial stages can bring about corneal folds, which also obscures the view. On the contrary, when air gets in the interface between the lens and the cornea when it is not properly placed, again it can obscure your view. The most important is to know your anatomy. The pigmentation of the trabecular meshwork and the blood reflex in the lens canals aids us to identify the angle structures clearly. We can zoom in and zoom out till we have a clear view. Goniotomy is done here with a Kuhug dual blade. The blade is held in the dominant hand and introduced into the anterior chamber. It rips off the trabecular meshwork. It smoothly enters the trabecular meshwork and the plate lies on the anterior wall of this lens canal. And then create a parallel incision in the trabecular meshwork. It exposes the collector channels and then reverse the blade and continue the same procedure. See bleeding from the exposed collector channels. You can always practice in the initial stage with a bang procedure where a 26 gauge needle, the tip of which is bent 90 degrees, and this needle is used to perform the goniotomy to rip off the trabecular meshwork. Once the surgeon gains confidence in identifying angle structures and doing an intraoperative gonioscopy, he proceeds to do the goniotomy procedures, and then now he is ready to do the other gonio procedures like the GADs and stents. Thank you.
So thank you, Dr. Bindu. From one young glaucoma trainer to a more senior glaucoma trainer. Dr. Andrews, please comment.
Yeah, first of all, I want to ask you about the title of your presentation.
It is MICS and not MS.
Yeah, I too wanted to ask about that.
Yeah, that was a...
Yeah, because it's all phaco converting to...
Yeah,
is it possible to convert from manual small incision to...
No, it is MICS, it is
Yeah, okay.
I think the title given in the video is MICS.
Okay, yeah.
Well, what did you say? Title given is?
Here it is MICS.
But what's printed is wrong.
Oh, okay.
Is what
Yeah,
you're
yeah.
saying. Okay.
Fine,
Okay, fine. Then, yeah, congratulations. Very nice presentation. I have a little bit of a query about the technique you've used. You've actually used sort of translatory motions rather than hinging on the incision. You've used a sort of, particularly with the bang, you've used a translatory motion to make your incision rather than actually go in a curve hinged on where it enters the limbus. Any particular reason for that, or is it just unfamiliarity of technique, or what?
Might be the unfamiliarity technique because I'm used to this technique.
Okay.
Can I just add another couple of suggestions? I think the presentation was excellent, but one very important thing is your chair position as well, because when you change the angle and start doing the procedure, more often than not, you'll have to sit quite low.
Away from, a little bit away.
And you have to go quite low. So the chair has to have a lot of flexibility within it. The other thing that I would also ask about your technique is using too much of the OVD on the corneal surface. You have to use the bare minimum on the surface. Don't flood it, because if the OVD gets onto your lens, your visibility goes totally bonkers. And to avoid blood in the field, your incisions have to be very corneal. So these are the few tips that I can say to improve your visibility. And of course, different MIGs have different techniques. And Andrew raised that thing about the bang procedure. And it's all the more important when you're doing the bang, because the tip is sharp, which is why a translatory motion will not get you around like with a KDB, because the KDB is not sharp at the tip. So your KDB technique to your bang technique has to have that slight modification.
Thank you, sir. Thank you for the suggestions.
Yeah, one more last comment is, when you are zooming up, see your quality of your recording. If it goes out of focus or blurred, don't zoom too much to make a video. It has to see clearly. Or if it's under low magnification also, it's fine, but it should be sharp. Thank you.
Thank you, Dr. Abhi, for those, I'm sure, very useful tips that you received, Bindu. So next speaker.
Thank you.
And calling upon the 6th finalist on stage, Dr. Sujitra H. Intralesional injection of sclerosing agent under ultrasound guidance. Dr. Sujitra, please.
Intralesional injection of sclerosing agent under ultrasound guidance in a case of orbital venolymphatic malformation. Orbital venolymphatic malformation is a rare benign vascular malformation which is seen in pediatric age group. It manifests in childhood as slowly progressive proptosis with displacement of the globe. A spontaneous intraorbital hemorrhage or venous thrombosis may cause sudden acute proptosis, severe pain, compressive optic neuropathy or loss of vision, which calls for active intervention. Diffuse form of orbital venolymphatic malformation is well known for its difficult surgical intervention and frequent recurrence. Intralesional sclerosing agent injection is one of the management options of this condition. Here we present a case of orbital venolymphatic malformation where we have given intralesional injection of bleomycin under ultrasound guidance. This 10-year-old girl presented with a complaint of forward protrusion of her left eye, which showed an increase in the displacement of the globe during upper respiratory tract infection and fever, which is characteristic of venolymphatic malformation. She had 2 previous episodes of sudden increase in proptosis and pain, for which she was hospitalized and was given steroid injection. She was referred to us for digital subtraction angiography and further management. On examination, the child had eccentric proptosis and limitation of ocular movements in the left eye. She also complained of diplopia and blurring of vision. Best corrected visual acuity was 6/6 in right eye and 6/9 in left eye. She was also found to have posterior subcapsular cataract in her left eye.
6-vessel DSA showed mild venous congestion in delayed venous phase in bilateral medial orbital region and no evidence of arteriovenous malformation, arteriovenous fistula or ectatic veins. MRI brain showed multiloculated multicystic lesion which was noted in the left orbit with both intra and extracorneal component causing proptosis. Intraorbital optic nerve was encased by the lesion with effaced perioptic CSF. Extraocular muscles were compressed and displaced laterally and medial rectus was stretched by the lesion. The lesion had features suggestive of slow flow venolymphatic malformation. The child was planned for ultrasound-guided intralesional injection of sclerosing agent bleomycin under general anesthesia. A USG scan was done using 10 to 12 Hz probe, and here we can see the image showing large cystic lesion in the retrobulbar and peribulbar space with blood inside the cyst. 4 ml of blood was aspirated under ultrasound guidance from the lesion. Fluoroscopy was performed to rule out communication with systemic circulation. Iodine-containing contrast Omnipac was used for the same. The contrast agent was seen pooling inside the lesion, confirming that the needle tip is well inside the lesion and also there are no communication with the systemic circulation. A 22-gauge spinal needle was used for injecting bleomycin into the lesion. The needle was visualized with the ultrasound probe and was passed carefully first into the deeper posterior cyst and then 2 units of bleomycin was injected. The needle was then slightly withdrawn and placed in the larger anterior cystic space and the remaining sclerosing agent was injected. Here we can see the bleomycin injection being accurately injected into the cystic space. The presence of the contrast has helped us in better visualization of the injected sclerosing agent. The child was kept under close follow-up. At 3 months post-procedure, the child was symptomatically much better, the proptosis had reduced and there was significant improvement in the extraocular movements and she did not have any complaint of diplopia. Doing this procedure under ultrasound guidance has helped us to give the injection accurately into the space and to avoid any damage to the extraocular muscles or the globe.
Thank you, Suchitra, but I have a slight problem with this. Not with the video, sorry. The video is excellent and everything. This was posted as also a poster competition. Suppose both win. What will happen? This is a video plus poster. Same case, I think, and same presentation. So I'm a little confused if that is acceptable. But since there is no rule for it, so we'll continue with this. Any comments upon it, please?
So I don't think there is any rule against it, no? So we'll mark it like a regular.
There's no rule against it, so please don't mark against it. This is just for the scientific committee to decide on this.
We'll all mark, madam, and then you can decide.
Yes.
I have just got a comment. The whole thing is a video presentation. So the procedure was fantastically done with ultrasound guided. If we had probably, the clinical aspects, examination, the ultrasound, other things had been a video, at least you would have integrated some more video into your presentation, like exam. It was one photo for a longer time, initial photo. Otherwise, the procedure was good, madam.
Any more comments? Thank you, Suchitra. And with that, we end this video award session. The entire videos are available at a kiosk outside. All of you can see all are very good videos. And so we now close the session. The award will be announced later. Thank you.